Good evening, everyone. Thank you so much for joining us. And thank you for Dr. Siddiqui for being here. This is really wonderful and really helpful. So I'm Chelsea Klein. I'm the Executive Director here at Cancer Connection, and I just want to take a minute to welcome you into the living room at our center and joining us on Zoom. Thank you for being here. I just wanted to take a minute to list off Dr. Siddiqui's incredible titles and let you know who we're learning from tonight. So he is not only the Medical Director of Medical Oncology at Mass General Brigham Cancer Institute at Cooley Dickinson Hospital. He is also the Chief of the Division of Hematology and Medical Oncology at Cooley Dickinson Hospital. And he's the Associate Professor of Medicine at UMass Chan Medical School, and he's been the medical advisor at Cancer Connection since 2023. So thank you for joining us. We're very grateful. And thank you all for being here. Laura's going to say a few words. Right, yes, Laura is our Center Director, and I will get out of the way.
Oh, okay. Well, all right. Yes, welcome everybody. I'm Laura, the Center Director. Just wanted to tell you, I think a lot of you have been here before, but if you're looking for the restrooms, we have two of them out this door. We have one to the right, and the other one is down the hall there, and you'll see them both. Feel free to get up at any time as you need. We also have a kitchen that has a Brita and some cups there if you would like some water at all at any point. But otherwise, we'll get going. Yeah, thanks everybody for being here. Yes. So yeah, we have some questions. Well, I guess one other thing that I will add is, so we had asked for everybody to submit questions ahead of time. So we've compiled them and put them together, also by topic. And I've given the questions to Dr. Siddiqui, so he's going to go through and start addressing all the ones that were pre-submitted. And then at the end, if we have time, we can take questions as they arise at the end. So we'll sort of look at timing. And we'll do that both for in-person and for ones that are coming in via Zoom. So that's how we'll address this.
Thank you, Lauren.
Yeah.
All right. Thank you so much. Thank you so much, Laura, Chelsea. Thank you so much for doing this. And thank you so much for everyone who came here and everyone online. So it's it's a pleasure to meet with you all and to do these sort of sessions. I'm a big believer in learning, and I learn myself also all the time, and even from my patients, a lot of time. And I think this is one of those questions also. And as we'll go over these questions, I think it's very important to know what's going on. The more you know about your disease, the better you do. So that's what I believe in. So, do you want me to start just with these questions?
However you want to go through, absolutely.
Yeah, so there are some journal advice questions, there are hospital related and cancer and treatment related questions. And please feel free to stop me if you have any questions from, as we are talking. So, the first question here is that, what is the single best piece of advice you would give to a cancer patient? And would that information change for a newly diagnosed patient compared to a long-term cancer patient? So I think I think there are two completely different scenarios. A patient who is brand new, who just had a diagnosis of cancer, as opposed to someone who has been on treatment for some time or who has been cured from a certain cancer, and they are just sort of in the survivorship period. So I think for the new patients, the most important thing really is cancer is really a life-changing diagnosis, and it requires a lot of support. Okay, and I think I always see that the more support you have, the better you do. So I think this is the time where you need whoever your family members are close to you and whoever your friends are. This is the time to sort of get everyone together and have them available for you, not just for, to help out with different things, for the, transport, for the taking you from home to the clinic and stuff like that, but even for emotional support. So I think that's one very important piece. The more help you have, more support system, the better support system you have, the better you will do. Then the next thing which we are doing right now is knowing about your disease. I think that's the one most important advice I give to patients, that just and ask as many questions as you have. No question is a stupid question. I always tell patients that just ask questions. Sometimes you get a satisfied answer, sometimes you don't. Just keep asking. Okay, sometimes providers are in a hurry and nurses are in a hurry, but keep asking until you get the answers. And I think as providers, this is important for us, and it's our job to make sure that your answers, your questions are answered completely. So know your disease, and then know your treatment, and know what it really means in terms of the taking those treatments and potential side effects and those sort of things. So I think those two things are very important. And the one other thing which is sort of common sense thing, it sort of applies to day-to-day life, is that our physical and emotional health. Okay, so don't watch TV, news and stuff. So staying physically active is extremely important. So you have to make sure that, and it's hard though. It's very hard, even when we are, when we are not going through any stressful treatments or anything stressful in life. Even then, it's hard to go out and do exercise. It's hard, So it's not easy. And when you are going through a stressful situations and treatments, which are making you feel more fatigued and more tired, and so it's hard. But what we know, and this is proven by multiple studies, that patients who stay active, and when we say stay active, we don't have to run a marathon. I mean, we're talking about 20-25 minutes of activity. Brisk walking is good enough. Something like that, 3 to 5 times a week. That really improves everything, and that also has a positive effect on the emotional health as well. And then emotionally, emotional health is again very important. Everything is connected to up there to the brain. So I think the more, and that sort of goes to the first point, that you really have to have as much support as you can from your family, from your friends. It's good to have support. It's good to have. This is the time to use all that support and feel good. It's I guess it's important to understand that the cancer is a very common disease. A lot of patients, when they come to us and they ask, why me? Why did I develop this cancer? And the short answer to that is it's just a very common disease. Just so you know that if you look at the statistics, 1 in 2 men and 1 in 3 women in this country develops a cancer. So it's such a common disease. So every family has patients. I would tell this to people when we are sitting and doing these talks, that half of us are going to have some sort of cancer. So it's a very common disease, and so we just have to deal with this. And the good news there is that there are so many good treatments and available. So that and a lot of our cancer patients are doing very well these days. So those are the things I think one has to focus on: getting support. It's know your disease. The more you know, the better it is. And then your physical and emotional health is very important. So any questions around that? Yes, please. Yeah.
I'm rather isolated. I live by myself. And although I have 2 sisters who have gone through breast cancer diagnosis, which is what I have, and I'm actually surprised it took this long in my case, I don't really have anyone to advocate for me.
Yeah.
And I'm not sure how to connect with that.
So I think that's where this comes in. Organizations like Cancer Connection here, and there are staff. There are in our cancer center, for example, our social workers. They're very helpful in terms of trying to find any sort of help patients need. So I think and then there are disease specific. There are groups out there where I think we can provide that information, and you can connect with the disease specific, whichever cancer you have, you can connect with the people who have those sort of cancers and talk to them. So I think it's important to have some sort of an outlet where you can
The
talk.
social worker over there, Lauren, she's fantastic. And the nurses in oncology are amazing.
I had
So-
not good luck with Lauren. I may have gotten her on a bad day.
Oh,
So
It's
I
possible.
feel very
it
shut
could
out.
be because
Yeah.
she's really, for paperwork or anything, like, I got a handicap sticker because she knew it was getting hard for me to walk further and further. And I was like, well, she did it anyways, but she's really, really good for that kind of thing. And the nurses, if there's something you don't feel good at all or any concerns, talk to the nurses. They are amazing.
I won't have a chance to talk to nurses until I'm there
Right.
on the day of my surgery.
Uh,
So
Hmm.
this is why, and also I haven't actually talked to my surgeon after she looked at me the first time.
Mhm.
yeah.
So, I'm just kind of
Do you
walking.
have any friends around or anything that can?
Acquaintances. I've been
Yeah.
talking to my pastor, and she's very kind. But what I actually need to feel is that I have an advocate
Mhm.
Yeah.
in the system. And my sense is that maybe in the transfer from Cooley Dickinson to Mass General, there were connections that were broken.
Mhm. We can always look into that.
Yeah.
I think the main people who sort of help out with that is our social workers. We have two,
Yeah.
and we can always, we can talk. You can let me know, and then I can look into this further. They are very good in sort of connecting patients with whatever help you need. So if you can, after this, you can give me your information, and I can definitely look into that and try to connect you. I can talk to them and make sure that you're connected. I know, it's not easy. Sometimes, in the clinic, sometimes everyone is busy running around, but they're always available. They will get back to you whenever they can. So I will make sure that we connect you with them, and yeah.
I just wanted to speak to that because there's another social worker there named Roxy, is who we worked with, and she was really helpful.
Yeah.
And also, I have found, and I don't know if it will work for you, was being on the portal. I get to ask my doctors more questions. I'm not an online person in a lot of ways, and there's this limit of characters. But when I'm the caregiver for my partner who has cancer, and I actually had cancer too at one point, but I'm cancer free right now. But if I want to talk to my surgeon or my doctor more than I had a time to do it, if I can really be specific about my questions and stuff, his whole care team has been really good about responding to portal messages. So you might want to try that. And I just want to throw that out so that you.
That's a very good point. Yeah, because if you don't, you should definitely be on the portal to sign up on the portal. And you can always send messages through there, and everyone is looking at those, and someone will get back to you. Because sometimes when you call, and you cannot get hold of anyone, but you can always, because everyone is looking at on the portal, so if you can always send a message through the portal also. Very good point. Thank you.
Yeah, the portal, they respond pretty quick.
Yeah.
Yeah. Good. Anything else? Any other question about this? Okay. So the next question here is that other than falling down the rabbit hole of the internet, what are the things that a cancer patient should avoid? Good question, actually. So as I said before, that it's important to learn about your disease, but these days, as we know, that there is a good information and there is some unnecessary information or even wrong information. And that's another problem these days, how to avoid the misinformation, let me put it this way. And secondly, the cancer care and the cancer diagnosis, and I think every disease is complex, but I think this is the most complex when it comes to treatments, when it comes to the disease itself. It's one of the most complex disease. one can think of. And it's sometimes hard to sort of connect the dots and to put the information together. So I think it's very important that before but that doesn't mean that one should not go online and try to find out, because there are really very good sites where you can go and find good information about general information about cancer. But it's important to first have a discussion. Especially if someone is a new cancer patient, it's always best first to go and see the provider, and then let them explain everything to you. And then yes, you should ask the questions, whichever the general questions you have, and then from there, then you start doing your own research, which is completely fine. There is really very good. For example, cancer.gov is a website. ASCO, American Society of Hematology. There are many good websites where you can find general information. And the other, I think that's even a better option, is that just ask your provider to give you some information. And so we can print out, or we can refer you to a certain website or a certain link that you can go and get some information from there. There's a lot of information out there on the internet, especially when it comes about how patients generally do, meaning that how patients do with a certain cancer in terms of, the survival and those sort of things. And that's a complicated issue, because there is no black and white straightforward answer to that. So and this is the best thing, is to discuss with your provider, because we can explain what does that really mean, because every stage is different. As I said before, the cancers are so complex these days that I'll just take example of breast cancer. Breast cancer is not just one disease anymore. Okay, every breast cancer is different. Every stage is different. They are treated differently. Patients do different depending upon what type of breast cancers they have. It goes anywhere from being the very, very less aggressive to be very aggressive. And there's a whole variety of different sort of types of. So it's and that's even when we talk with the medical doctors, not the oncologists, about these things. Even it's hard for them to understand. Sometimes things are so complicated these days that I'm a general oncologist. I do everything. It's very hard to keep up, because, as you know, that there are subspecialists now. There are oncologists who only do just breast cancer. The patients, or the doctors who do only lymphoma, for example, or only lung cancer. So things are so subspecialized, because things are becoming more and more complex. So it's important to understand that you are not looking at some information which probably is giving you something wrong, and you're getting more stressed out about that. So I think it's best to have a discussion. It's always good to have someone else with you when you go for your first appointment, especially, so that it's always good to have. And these days, actually, it's also fine to record your appointment or your discussion. Yeah, I mean, we allow it, and a lot of patients do that. And I think completely fine, because you are getting a lot of information. You are hearing from different things from different people. So it's also a good idea to just record the conversation so that you can listen to that at a later time. So I think all those things, but it's a very good point, though, that yes, it's always good to learn your disease and get more information about it, but it's also important not to get something wrong information about your diagnosis. And that the next question here is on the asking the same thing, that there are, with more patients now using tools like ChatGPT and online research to understand their diagnosis and treatment options. What advice do you have for integrating that information into conversation with their care team? How can patients use it productively during appointments? And are you finding when they come to you to be accurate? So again, the same thing here is that ChatGPT is very helpful for many. We actually use it in many different ways in our own the way we practice now. Some of our official tools which we use are actually based off ChatGPT or AI. So technology is always good and it's very helpful. But again, I think it's important to, because what's important is that when someone, a physician is looking at some information, they're looking at that information with a background of some knowledge, whatever, 15, 20, 30 years of knowledge and experience, and then it's, as opposed to if someone's just looking at it, trying to understand those things. So it may be difficult, and sometimes it may be misleading. So it's important to use those tools. But again, if there is any confusion about anything, you can always write it down, and you can talk to the provider when the next time you go and talk to them. For example, one of my patient looking at their blood work. Now, as you know, portal is available; everyone can look at everything. So they're looking at everything now. So they're looking at the blood test. There are so many things in your blood test which we simply ignore, which are there for just there to report, but they have no really clinical value or importance. So we just ignore those things. But if you put that, okay, for example, and there is something called MPV on your blood test is abnormal. If you put that in ChatGPT, it will give you a differential of 12 different diseases. And then I talked to them. I said, listen, we will. So don't worry about that. This is something completely because things go up and down all the time. So please ignore that and don't worry about that. So that's important that when you are, you don't want to miss things, but when you are overreading things, that just creates more more stress for you, and so I think it's best to not to do that also. Okay. Any questions about that? Oh, yes, please.
So, as far as reliable websites, is that something that you could ask a befriender or someone at Cancer Center about, because I would think folks here might have an idea about these are websites we trust with information about cancer. These not so much, or whatever.
Yes.
Yes, we have vetted sites. Yes,
Yeah, that's
sites
what I
that we do recommend. Yeah. So you can talk to any of the befrienders if you'd like some resources like that.
Thanks.
Yes, please.
Is it useful to find out about comorbidities?
You mean comorbidities? Yes. Those play a very important role in everything. So obviously, when we talk about anything, treatments, we always factor in those things, other comorbidities. So it's important that the provider who is treating you should know all those things. And they are usually part of that's what your question was, right? For example, if someone...
certain kinds of cancers related to other kinds.
Mm-hmm. Oh, yes. Oh, you mean if you have some sort of a cancer, then the risk of having another cancer?
Yes.
Yes. So and that goes back to the point of risk factors. There are certain risk factors which are common for many different cancers. I can just give you one example is, for example, smoking. Smoking, we used to think of lung cancer, but now we know smoking causes every single cancer you name it. Yes. Smoking is associated with all sort of cancer. So when you have a cancer from some sort of a risk factor, then all these other cancers which can be from those. And we actually, these days, we see patients with multiple cancers. And that has become a sort of a more common these days, for whatever reason. I have patients who have 4 or even 5 different cancers. And again, doing well, being, treated, receive treatment, cured from it, and they got something else and then something else. But yes, so we're seeing that more and more commonly, just because going back to the same risk factors, which we'll talk about that a little bit about that as well. Did that answer your question?
Yes, thank you.
How can patients and caregivers effectively advocate for themselves within the healthcare system? I think we sort of briefly touched on that. I think the main thing really is that make sure that you know your disease, make sure that you know what your care team is and how to get in touch with us. She brought it up very nicely that you can send them a message, use your portal. I think it's important just to know your team, know the people you're working with, and so that you can get in touch with them, and it's as if you have again family and the friends, it's always good to have someone with you, especially at the time of the initial appointments, initial diagnosis. It's always good to have another set of ears to help understand things better. What are some recommendations you tell patients that help them move on after their treatment is over and to no longer identify with cancer as part of who they are? So I think they are asking about the we call that survivorship time. Survivorship time basically is that when someone has completed their treatments, and we generally say that 5 years after the cancer diagnosis is the time period we consider if cancer hasn't come back by 5 years, that most of the patients are cured from it. Most of the treatments also end by 5 years, although things are changing now. Some patients are on treatments even for more than 5 years or even 10 years. But survivorship care is a whole something which one has to, important things to understand that once you have a diagnosis of cancer, so even if you are cured from it, 5 years have passed, there is always a risk of that cancer coming back, although very small, but then there is always a risk of having similar type of cancer again. For example, again, I'll give you an example of breast cancer. We have patients who had breast cancer 10 years ago, and now we are seeing them again for a second new breast cancer. So it's important that your risk, if someone has any type of cancer, their risk of having the similar type of cancer is higher than average. And then again, going back to the same point, similar risk factors. So if you have a history of any cancer, your risk of having something else, which is, for example, I'll give you an example. Smoking is related to very commonly with lung cancer, but also very commonly related to head and neck cancer, and or even GI, esophageal cancer. So we see that quite a bit, multiple cancers in the same patients. Most of the cancers after 5 years, the guidelines do not recommend continuing surveillance in terms of doing the scans and stuff like that. But although these days we continue to see patients, depending on what type of cancer they have, we continue to see patients once a year, making sure they're undergoing the appropriate screening and they are doing everything, again, so that they can get back to their normal life. And that also, requires takes some efforts and work. And again, even in that survivorship time is also going back to the same physical and emotional health. Those are the things which one should continue to work on, make sure that. So now we are moving on to hospital-related questions. Anything else about these things we discussed? Any questions? Yes, please. Yeah.
I'm good at asking questions. Can I share about your diagnosis? So he has metastatic prostate cancer.
Okay.
So my understanding is he will be in treatment for the rest of his life, basically.
That is correct.
Okay.
Yes.
So most cancers, and you have the spine.
Yes, and prostate cancer is, just so you know, it's the number one, the most common cancer, is the most common cancer in men. And it's one of those cancers which is by nature, it's not a very aggressive cancer, which is why patients even with stage 4 prostate cancer, they do very well on treatments. But yes, once you have a stage 4 cancer, most of the time you stay on some sort of treatment for the rest of your life. Sometimes there are some patients who we call something called NED, meaning after doing certain treatments, they become NED, meaning no evidence of disease on the scans, and they are in sort of a remission. And sometimes they can take a break. So it's always okay to ask for a break or to take a break. Quality of life is important. So if you're doing fine, if everything is stable, PSA is good, and your scans are fine, so once in a while, taking a little break here and there, it doesn't hurt.
Thank you.
You're welcome. We okay? No, okay. So the I think the next questions are hospital-related questions. So this is not a question. Would like to give a big thank you to CDH, to all the oncologists, chemotherapy nurses, radiation oncologists, and radiation technicians, testing and support staff. Everyone I have interacted with has been kind and helpful during a very rough time in my life. So thank you so much. Whoever said that, thank you. It's always good to have feedback. Very important question. Next question is, what is the relationship between Mass General Hospital Boston, which actually is now we are Mass General Brigham Cancer Institute? Because as you know, MGH and Brigham and Women's, they have joined. They are one organization now. I'm very excited and proud of that. This is one of the largest system in the state now. So MGBCI and the relationship with Cooley Dickinson Hospital is the merger between the two hospitals, more of a merger between the CDH Cancer Center and Mass General. So yes, so I think this is very important, and this is something which we all have to be proud of, and who live in this area, who are part of the community here. That so for any cancer management, it's the key is that you are getting the best treatment near your home, and that's because it's and you all have been through this. It's not easy to when you are going through all these different difficult treatments, and on top of that, if you have to drive to Boston or somewhere else for that, to get some treatment. So it's very stressful. Just the drive to Boston is stressful. Thinking of that is stressful. So I think what CDH and this merger with MGBCI means is that we have all the best advice and the best treatments, and we're not talking about in the state or in this country. We're talking on the world. I mean, MGBCI is the number one of the best cancer centers in the world. So and if that help is available to us, and then available to you, I think that's a great thing to have. What does it really mean? What this merger, as I mentioned before, that since cancer management and treatment is becoming more and more complex, and that we need to have people who are more subspecialized, because it's hard to keep up with everything, all the advancements, the research. So the way it works is that we have all the help available at just a phone call away. I can just pick up the phone. I can send a quick email. I just saw this patient. This patient has this and this and this. What should we do? Let's say if I'm not clear, and they just get back to you right away. And then we have conferences, which are very specific. So I think National MGBCI has probably 28 different subspecialty clinics. I cannot even name 28 different cancers, but so that this is how subspecialized things are. So and that's because if I'm sitting somewhere else in a cancer center anywhere else, and then I don't have this connection, it will take weeks to be able to get that advice or to get that help, or to be able to the patient to go and see them, as opposed to, since we are part of them, so we can just get that advice right away, and we can have our patient see them. Let's say if we feel that patient has to go and see them at least once, sometimes they can do virtual consultation. We can just call them, talk to them, and they're able to see our patient the next day.
Helped me out in talking to
Sure,
Dr.
example.
Kim.
Yes.
I asked, if I could have a phone conversation with her, and he did let me, which was great. It just backs what he's saying, because she's in the conference with him every week or whatever.
Yes.
So yeah, it was really reassuring for me. Like, it was nice. It was really nice.
Yes.
Thank you.
And we unfortunately do not have the clinical trials open here at this point in time. Okay, this is something which is in the works, and we're hoping that at some point in time we'll have some, because you need the whole setup for that. But our cancer patients who are let's say who are candidates for the clinical trial, they can always participate there. We can do whatever we can locally. As you know, we even have a shuttle now, which goes from here to there every day, and that's a great help. Yeah, so a lot of our patients use that. So I think this connection is the key here, and what this is giving us is giving us the best of the two worlds, that you are getting the best care this close to your home. So we're very proud of and this connection with them. So the next question is, can cancer patients at CDH make use of services at Mass Gen, either therapeutic, integrative, or clinical? For example, can CDH cancer patients go to Boston for certain treatments, scans, or other services that may not be offered at CDH? Are there other services for cancer patients at Mass Gen that CDH cancer patient could be making use of? Yeah, and we just discussed that. Yes, please. Yeah.
Is Dana-Farber affiliated with Mass General Brigham?
Good question. Yeah, so Dana-Farber is a separate entity now.
Okay.
So yeah, I think it's important to understand that. So the Dana-Farber was part of Brigham and Women's Hospital.
Okay.
So Mass General MGH, Mass General Hospital, and Brigham Women decided to be partner and to become one. Dana-Farber decided to go on their own, separate, and they are going to be part of BI Health, Beth Israel.
Oh.
So that's another system. So as you know, so Harvard has three main hospitals: Harvard Medical System, which is MGH, Brigham and Women, and BI. So Dana-Farber is going to have their own. I think they're going to have their own separate hospital at some point in time. But that separation is happening right now. I think by 2027 sometime, that separation will complete, meaning that they won't be there physically right now at Brigham and Women's, but they will eventually be a completely separate entity.
Thank you. Because somebody asked me where we were getting treatment, she said Dana-Farber, and I said, well, Mass General Brigham at Cooley. And she said, oh, that is Dana-Farber.
We are part of MGBCI, so we are not part of Dana-Farber.
Thank
Yeah,
you.
you're welcome. Any other question about that? So the next question is, I understand that there are integrative therapies like massage therapy, Reiki available at CDH, but how do I get an appointment? I have been told that they will reach out to me, but so far I don't see that happening. Is there a particular person or department I need to contact? Yeah, so we do have all those. I think, but we usually, again, our social workers are the ones who can connect, or our front desk staff can connect patients to them. So sometimes I think it takes some time before they get back to you, but they should. And if they don't, please call the office and make sure that that they send you information to them. And
they told us those aren't available unless you're in chemotherapy. That's when we asked.
Oh, you okay?
They said the integrative therapies, acupuncture, massage, and dietitian would be available once you began chemo. That's what the scheduling.
That is correct. When you're on treatments, yes.
Right.
Also, they're asking if they are not on treatment.
Well, he's on hormone treatment, but not yet chemo. And
but that doesn't matter though.
Okay.
So yeah, so that doesn't matter. Because chemotherapy is not the only thing we are doing these days. As you know, we are doing so many different things these days: immunotherapies, targeted therapies, hormone therapies. So it doesn't matter whichever. It's basically, if you are on any sort of active treatment, then you should be able to get all those therapies.
But Dr. Siddiqui, if someone is on tamoxifen for 5 or 7 years, would you consider that you would your integrative? Is there hormone treatment that is considered more in active treatment versus in survivorship?
No, it is active treatment.
So you would give it to someone who's on hormone treatment.
Because at scheduling, they told us what I just said to you, but I'm hearing, you should
thought
ask that question again. Because thank you.
And I can clarify this also, but as long as you're on any sort of treatments, you are on treatment. So it doesn't matter which type of treatment you're on. I think you should be able to. But again, I think it also depends on how many slots are available or how many people are available. I think it comes to that also. But I think if you're any sort of treatment, you should be eligible for that.
Thank you.
You're welcome. All right. So I'm going to go to the next section, cancer and treatment here. So anything else about what we discussed about from the hospital related stuff? Okay. So the next question here is that with the advances in genetic manipulation, do you think that in the future some cancer types will be cured rather than just managed? So, very good question. Actually, it's already happening, and I can give you an example of lung cancer, for example. So the lung cancer is a tough one, and lung cancer patients don't generally do well. At least in the past, when we look at the survival for any cancer, so we look at something called median survival, then we look at something called 2-year survival, 5-year survival, 10-year survival. Which simply means, so median survival simply means that the time period when 50% patients with a certain cancer are alive, 50% patients have passed away. In other words, what's the sort of a 50% chance of time. And let's say, for example, if I say that median survival for a certain cancer is 9 months, that means that 50% patients will be alive at 9 months, although 50% probably, they have passed away from less than that time period. And then those patients who are alive at 9 months, and then the next question is, okay, what's the chances of 2-year survival? Meaning that how many those patients are alive at 2 years, and that can be anywhere from 5%, 10%, 20%, and then we go to 5-year survival, then we go to 10-year. So with lung cancer stage 4, I'm talking about the median survival used to be with treatment used to be around 9 months or so, 6 to 9 months. Then 2-year survival used to be around 10%, 15%, meaning only 10 to 15% patients were living at 2 years out with stage 4 lung cancer. And the 5-year survival used to be only 0 to 5%. But now, the same stage 4 lung cancer patients, 20% of them are living at 10 years. And so you can see that. I'll just give you just one example, because there are so many other examples that things have improved so much with these new information about different genetic changes in the cells. When I was going through my fellowship, the only mutation at that point in time was only EGFR mutation. And now we have 7 or 8 different mutations, which we can target with different targeted therapies. We did not have any immunotherapy around it. Now we have multiple different immunotherapy options. So things already have changed a lot, and they continue to change, because we used to have, for example, for certain cancer, we used to have maybe just 1 or 2 options, and after that we used to tell patients, okay, sorry. And now we have options after options after options. Yeah. You are an example of that. Example. Yes. And that's the great thing here, is that the things are really heading in the right direction, in a good direction. Most of the stage 4 cancers we're still not seeing that. But things have improved a lot. It's still not considered curable. But again, I tell patients, think about about these. Think of a cancer as a chronic disease. We have not been able to cure hypertension. We have not been able to cure simple arthritis or diabetes, for that. So those things are not curable. You just live with those things. You take your medicine. It keeps things under control. So think of cancer the same way. Many of the cancers actually these days are like that. The patients are on some treatment. Many times it's a pill. You're taking a pill at home, as you take with other stuff, and you're just managing, and your things are stable on that pill or whatever medicine you're on, and you just living your life most of the time. The good news there is that most of these treatments now, the targeted therapies or immunotherapies, do not have that same type of toxicity which the conventional chemotherapy has, and things have improved from that standpoint also. So a lot of good news there. Then I have a few questions about radiation. Just a disclaimer, I'm not a radiation doctor, but I will try to answer those best of my knowledge. So does radiation ever leave your body? So radiation treatments, once they are done, they do leave your body. But the radiation, when you think of radiation, we live in a radioactive world. There's radiation all around us, some sort of radiation. But the radiation treatment which we get for different cancers, that does not stay in the body. That basically is out of your system when you are done with your treatments. The effect may last. So those two different things. In other words, it's not that if you have received radiation therapy that that radiation you can transmit that radiation to someone else you are close to. That's not the case. It's just that you receive radiation therapy, but the effects sometimes may last. For example, let me just give you an example for example, for breast cancer patients who receive radiation therapy to the breast. Now, just underneath the breast, there is lung. Many times, some patients end up having some damage to the lung. Although minimal, these days, radiation therapy machines are very smart, techniques are very advanced, so most of the time, the way these things are done, not too much damage is done to the surrounding area or the lungs underneath, but still some sort of damage can happen to those to the areas around it, and that usually resolves over the next few months or so. And the other question is about the radiation also. How safe is radiation in your body? So radiation therapy these days is very safe. Now, radiation itself is a risk factor for cancer. So too much radiation, we know, right? We know that radiation exposure, too much of even a recent study have shown that the patients who undergo CAT scans after CAT scans after CAT scans, because we are monitoring things, that increases the risk of, because there is some radiation exposure there, increases the risk of other cancers. But it's generally radiation therapy is safe, and the radiation which we get from the CT scan and the PET scan is also safe. Safe in a way that the amount of radiation which we end up receiving is not to that cutoff where we worry too much about cancer development. So overall, radiation is considered very safe, minimal side effects because it's a local therapy. It does not go into blood, so it doesn't have any systemic toxicity. So radiation is most of the time, wherever it's given, it just affects that area, kill the cancer in that area. Yes, may damage a little bit the surrounding tissue, but that heals with time. It's just a matter of weeks or months, it heals. So radiation is safe. And then there's a question about what issues can you have from radiation. Again, it all depends on where the radiation is being administered. As I mentioned about the breast, that they can affect the lung. For prostate, for example, the bowel is there, the bladder is in the way, so there are some side effects to those areas. So it all depends on where you are getting. For breast, for example, the skin also gets a hit. Some patients have a significant skin toxicity from radiation. Some patients have mild or minimal. It sort of depends on multiple things. For brain, for example, for brain radiation therapy, there is some long-term toxicity, some brain fog, sometimes some memory issues can develop down the line. And since our patients are now, which is a good thing, our patients are living more and more after receiving these treatments. Now we are seeing more and more long-term side effects from these different things. And it's the last question here is, do you recommend having a colonoscopy if your linings inside have been radiated? So the short answer is yes. After radiation, if the radiation is done to the bowel, that inflammation usually goes away in a matter of weeks. So if someone needs another colonoscopy, then it's completely fine to do that. All right, so I think we have done with these questions, but we can, if anyone have more questions, if you have any questions from the.
Both pages. I don't see anything that's come in online. Kendall's going to be sending them to me, but nothing's coming online, so we can start with anything in person.
Can I ask
question.
Sure, please.
If you don't feel comfortable answering,
No.
what are the surveillance measures when the patient is all done with the treatment
Mhm.
and mastectomy surgery,
Mhm.
where mammogram is no longer indicated?
Mhm.
What other scans?
So for the
or
breast
any-
cancer you're talking
Yeah,
about.
or any
Yeah.
other surveillance measures that
Mhm.
you would recommend?
Sure, no, it's a very good question, and it's different for different cancers. For breast cancer, for early stage breast cancer, where patient has undergone all the treatments and the surgery, and they are either on hormone therapy or something else, the guidelines do not recommend doing any surveillance scans, and there is a reason for that. Um, the By the way, things are also changing, and I hope that I don't forget. If I forget, please remind me. I'll have to talk about something else about this. So in general, the surveillance is with the scans is not recommended. Actually there are two big studies done in the past. One was for breast cancer patients, big studies, where they have several hundred patients with early stage breast cancer who underwent regular scanning after every 3 to 4 months, looking for cancer coming back, and that there are certain patients, several hundred patients, who did not undergo any scanning. In the end, the study showed that the patients did the same, meaning that the survival was not affected by doing multiple scans at certain set intervals. Um, Although the patients who were undergoing the scans on regular basis, they did actually poorly. Why? Because when we are doing scans and when someone has a history of cancer and we are seeing these little things here and there, and we are worried about that, patients are anxious about that, and then we start to put needles here and there, try to figure out what is what, and that led to even more complications, procedure-related things. Because, yeah.
When you say scan for breast cancer, are you including mammogram?
No.
Okay.
No,
yes. PET or CAT?
Yes, yeah,
Okay.
PET scan and CT scans, yeah.
Okay, thank you.
So for which we do for other surveillance for other cancers.
Yep.
Ultrasound too?
So no, that's different too.
Uh-huh.
Yeah. So and I'll come to that. So what I'm talking about is the surveillance scans to look for cancer recurrence anywhere else, and for breast in particular, the guidelines right now say don't do them. Okay, and the reason is simply that the studies did not show any difference in terms of, because if something is going to come back, no, breast cancer is highly curable. All right, if it's stage 1 to highly curable cancer, over 80-90% cure rates with the treatments. So if something is going to come back, it will start to cause some problems, and then one would know either the provider or the physician will find something wrong, or patients will tell something which would be abnormal, and then we'll do scans and find out what's going on. But to get back to your point of the screening, so mammograms and ultrasound are still mammogram is recommended. Depending upon mammogram, we do ultrasound. That should continue. Some patients need MRI also, screening MRIs in addition to mammograms. It all depends on the situation, their age, how dense their breasts are. Sometimes we recommend both moving forward after they are done with the initial treatments and surgery. Now, for patients who have undergone mastectomy, bilateral mastectomy. Now, mastectomy ideally means that all the breast tissue has been removed. So if the breast tissue has been removed in entirety, then there is no breast tissue left, so there is no really risk of breast cancer coming back. And then so mammograms, basically, they're not indicated. Sometimes when there is concern about something left behind, sometimes MRI can be done of the chest wall to look for things. But in general, if you have undergone mastectomy, there is no need for any more scan. The guidelines don't recommend doing any imaging studies for that. Although the cancer can come back still, very rarely it can come back on the skin. So all it needs is one cancer cell hiding somewhere, and then go somewhere, it hides somewhere, and then it becomes active 3 years or 5 years down the line. Sometimes it's in that same area, sometimes it's in the axilla for breast cancer, sometimes it can show up somewhere else. So the scans are generally done on as needed basis or as indicated basis. Yeah.
You had something else that you wanted to return to.
Oh yes. So the imaging is, so it's very again important to so screening, it saves lives. It's extremely, even if you have been diagnosed with a cancer and that has, keep in mind that it's even more important for people who never had a cancer, but screening is extremely important. And for breast cancer especially, because sometimes some guidelines say that it's okay to do a mammogram every 2 years. Actually, that's the guidelines by the United States, the Preventive Service Task Force. But the other guidelines, the most of the cancer guidelines that we follow ESCO, and they recommend every year, because many times we see patients with a breast cancer who had just a mammogram just last year was completely fine. So it's important to stay on track of that, and once a year. There are now more and more younger patients are being diagnosed with breast cancer, and the younger the patients are, the higher the chances of having a dense breast. And what dense breast simply means is that the risk is much higher of missing something on the mammogram. So the sensitivity of the mammogram can go down as low as maybe 70% from 90-95% in a non-dense breast. So I think it's very important also to keep in mind there is a special type of ultrasound now available. I don't think we have it yet, but that's something which is like a whole breast ultrasound in addition to mammogram that increases the sensitivity of picking cancers. But more and more we are doing MRIs these days. If someone has especially a younger woman when in dense breast, we also recommend doing the MRIs as well. Yes, please.
Can you explain what a signal node biopsy is?
Mm-hmm. Sentinel lymph node. Yeah. So basically, how does cancer spread? Okay. So all of us sitting here, we are making cancer cells all the time. Our body is making cancer cells all the time, and our immune system is like they're watching immune system, and the lymph nodes are the glands which are part of our immune system, which we have everywhere. We have superficially, as in the neck, the axilla, and the groin area, and we have lymph nodes. We have hundreds of them inside also, right? So every organ in the body is drained by something called lymphatic channels or lymphatic system. So all the fluid, the blood that goes through the body, and there is every organ is drained by lymphatic channels, and those lymphatic channels are connected to those lymph nodes, and all those lymph nodes are connected with each other. Whenever or wherever a cancer develops, a cancer cell starts to grow. 90% of the time, the spread, that cancer cell, when it starts to grow and once it breaks off, and that's the main worry, because the cancer becomes from early stage to stage 4 by breaking off from the primary tumor and then going into either the lymphatic channels or into the blood system or into the blood vessel. Most of the time, 90% of the time, the cancer cell ends up in the lymphatic channel, which is a separate system, in the lymphatic, teeny tiny lymphatic vessels. From there, the fluid goes into the lymph nodes. Now it's the job of the lymph nodes to make sure that, okay, this cell looks bad, looks cancer cell, kill it. And they try to kill it. And most of the time, 99% of the time, it takes care of, we don't even know, we're not even aware of that, what's happening in our immune system. But sometimes, when for any reason the cancer I always say the cancer is the smartest disease, some very smart disease. So it can figure out a way so that now the lymphatic the lymph node is blind in a way that it cannot see that cancer cell for some reason, because the cancer cell develops some changes and it's on its outer structure, and it can escape that immune check. So if that happens, then that cancer starts to grow in that lymph node. That's how the cancer spread 90% of the time. But 10% of the time, it can also spread by blood. But that's rare. Sentinel lymph node is that if there is a cancer growing, and that will, the channels, all those lymphatic channels go to a certain lymph node, that may be 1, 2, or 3. From there, it go to the next lymph nodes and go to the next lymph node. So the sentinel lymph nodes are the first few ones. So in other words, if the cancer has not gone to the sentinel lymph nodes yet, that means it has not spread. There is a small chance that it might have spread through the blood channels, but that's rare. So what we do, especially in the breast cancer and in the melanoma, that we check sentinel lymph nodes. And if they are negative, then we stop. We don't do any more surgeries, because most likely the cancer has not gone beyond that. Sorry, Isma.
You
Yes, please.
mentioned it
Yeah.
spreading through blood channels.
That's a rare scenario. 90% of the time, it happens through lymphatics. 10% of the time, which is why even in breast cancer, for example, when we know that we have removed the cancer by surgery, and the sentinel lymph nodes are negative, we still treat patients, for example, with endocrine therapy, because what we don't know is that what we know about that we know the lymph nodes are negative, so there is no chance of cancer spread through lymphatics. But what we don't know is that 10% chance through the blood vessel spread, and that cell may be hiding somewhere. And that was actually the other thing I wanted to. These days now we have the research going on to look for that cell. Now that's not something which is currently approved, but the testing is there now. There are clinical trials who are enrolling patients, and we do have those trials. I think we have a trial for rectal cancer and maybe for breast cancer also in Boston, where they are looking for those cells. In other words, there's a special blood work they do and they find, but the problem there is that what does that really mean? Now that doesn't mean if you have a cancer cell hanging around somewhere and we see it in the blood, does not necessarily mean that cancer cell is going to end up in cancer somewhere. It's also possible that your immune system will take care of it. So in other words, at this point in time, the guidelines do not necessarily recommend doing anything, even if those things are found. So that's why the research is going on right now.
So it's not connected with CLL?
So CLL is different. So the blood cancers are completely different, because blood cancers are already in the blood. So that's a completely different situation. Yeah. You had a question, yeah?
Yeah, you had mentioned melanoma. I'm wondering if you've heard of anything on the horizon for scanning with any manner of things for people who have a whole lot of skin cancers.
So skin cancers are, as you know, they are melanoma and there are non-melanomas.
Yeah.
Actually, skin cancers, non-melanoma skin cancer, the basal cell squamous cells, they are the most common cancers. We don't even consider them cancers. We don't even include them when we talk about cancer statistics. Actually, basal cell skin cancer and squamous cell together, there are more of those cancers than all other cancers together. Okay, because everyone has these, you'd go to dermatology, they just take it over, they freeze it, they do whatever. So those are the cancer which we don't worry much about. All you need is,
except for the basal that grows ganglia.
Yes.
Yeah.
there are some which can be problematic, But rarely, but most of the time, if a dermatologist or a surgeon can remove them completely, that's all you need. Melanoma is a different story.
No, I understand that. I'm wondering if there's any, for people who've had a lot of skin cancers like me, if there's any scanning that can
Preventative
see,
scanning.
preventative, so they would see things even before you or your dermatologist see them.
Oh,
You know, like it's growing before it appears on your skin. You know?
I don't think so. I am not 100% sure because the problem is that we don't see those patients because basal cell and squamous cell cancers are not even sent to us. They just go to dermatology, they take care of it. But as far as I know, I don't think there is anything I'm aware of that can sort of screen that. I mean, I know what you mean. You're saying there's something, as we have screening for other cancers, something screened before they develop. I don't think so, yeah. I don't think so. I mean, the bottom line there is that if you are someone, and there are some patients who have multiple skin cancers one after the other, it's just important to make sure that you are seeing your dermatologist and they are taking care of that.
Yeah.
As long as you have them removed or they freeze, you have to do whatever they can, that's all you need. Very, very rarely they spread to other areas. That's very rare. But melanoma is a completely different situation. They're one of the most aggressive cancers, and which is why it's important if you have any mold on your body changing in any way, it's important to just see the dermatology, and that needs to be taken care of.
You know, I started with melanoma. Then
Okay.
worked my way down. The one that was a big surprise to me was the basal
Mm-hmm.
that can grow.
Yes, that can grow deep.
Really deep. Very
Yes,
deep.
yes,
Yeah,
and
I
that
had
sometimes
no idea
requires.
that could happen.
Yes, that requires more extensive surgery, sometimes even grafting and stuff like that.
Yeah, and I've had xanthoma and things other people have never heard of. You know.
Yeah.
So.
So maybe I have a question. You were talking we're talking about the sentinel node biopsies, and so it's seems pretty routine when you're having the surgery that they remove one, maybe sometimes two if they're kind of together to check to see that. Can you speak about the risks of lymphedema if you just have that basic one or two removed? And
sure. Yeah, so the lymphedema is basically is the swelling of the lymph because because all these, remember I just mentioned that all these lymphatic channels, teeny tiny, they're connected to each. There's a whole network of that in the body, and then they're connected to the lymph nodes. All of this is connected to each other, and if there is any sort of disruption to the flow, then the fluid is not being drained, so it's going to cause swelling. So, and that used to happen, and we used to see a lot of that when we used to do something called axillary lymph node dissection. Before the sentinel lymph node procedure, basically when a woman had a breast cancer, the guidelines recommended just take out all the lymph nodes. Now there can be anywhere from 10 to 20, 30 lymph nodes. And that used to be a lot of morbidity from that. Almost every patient had some degree of lymphedema. With the sentinel lymph nodes, when the surgeon is removing only one or two, maybe maximum three lymph nodes, the lymphedema issue is not that common. I think it is less than few percent points in patients, who develop. And by the way, there has been some recent studies showing that in certain patients, certain women, even sentinel lymph node biopsy procedure may not be needed. But that's not for everyone, though. That's for women who is above 70 years of age, has small cancer, ERPR positive type of cancer, and the studies have shown that in those women, all you need is just do an axillary ultrasound and MRI. Everything is negative. You don't see any abnormal lymph node. You don't even do a sentinel lymph node. So that's even a good thing now that some patients don't even need that anymore. But the risk of that with sentinel lymph node is way less.
Is that low risk based on following the guidelines of say like no, saunas, hot tubs, long hot shower? Like, is that number based on someone having to take precautions their whole life, Or is that just based
No.
on the low risk?
Yeah,
without
no,
that?
just like I don't think that patients who have undergone sentinel lymph node, they need to follow that sort of restrictions, in terms of, the blood pressure, taken on the or accessing the IV line, and so it's not the same
You don't
thing.
think so?
Yeah, no. So the restrictions are not same for those patients. Yeah. Yes.
So, getting back to sentinel lymph nodes.
Yeah.
Like I had a lumpectomy, I had 4.
Okay.
So then I went to get my COVID vaccine, and the nurse giving it to me said, it came up in discussion, she said, you never want to get a vaccine in that arm, you don't want a blood pressure.
So and I actually had a patient.
Can I just?
Sure, I'm sorry, yes. Oh, yeah.
And she said, you don't ever want to get, so always use your other arm.
Mm-hmm.
And then I asked my surgeon, I was like, yeah, you didn't say that to me. And she said, well, she didn't think it was a big issue. She said, maybe if you were in the ICU and you were having like blood pressure taken every minute. And I was like, I'm an err on the caution kind of person. So I'm like, okay, I'm just always using this arm. And I just wondered what your thoughts were.
Yeah,
about that.
so actually, some patient asked this just today, asked this question. So people are still thinking of that scenario where patients had full axillary lymph node dissection. But there are people are not, because with that, if someone had a full dissection, then yes, just to all of that.
Okay.
But with this sentinel lymph node, only a few lymph nodes, there is not much disruption happen in the axilla. There is still flow, and especially if someone who would not have any type of lymphedema issue, that means their circulation is fine, it's not affected. So the restrictions are not that much. Yes, if you have an option to use which arm, I think it's always best to use the one where you never had any intervention. But after 5 years, 10 years, if you never had any problem with that arm, I don't see any issues in terms of getting any injection or, But that the problem is that if you tell someone about that, they will tell you the same thing which they just told you, not understanding that things have changed, the techniques have changed, and sentinel lymph node biopsy is a much less procedure as opposed to the lymph node dissections. You're welcome.
Maybe I can ask a question.
Sure.
Very general.
Sure.
For cancer patients, is there any specific diet in
Thank
terms
you.
of nutrition that you would recommend?
Thank you. That's a great question, actually. So, some of those things are sort of, we say common sense, healthy diet and all that. But it's extremely important to make sure that during the treatments, what you are eating and how much you are eating, because all these different treatments affect your body in many different ways. It affects your appetite, it affects your taste. Now, you're not up to the reason we like to eat because we enjoy the food, right? And unfortunately, that is to some degree gone when you are receiving some, especially chemotherapies. So it's very important to make sure that you are getting a good, healthy, balanced, adequate nutrition. I tell the patients all the time, it's not a time to do dieting. Okay, a lot of patients, maybe I should lose some weight now. I said, no, this is not a time to lose weight. Okay, this is a time to maintain weight, and just make sure that you are eating what we all should be eating all the time, and which basically means that a balanced, healthy diet, which means that more vegetables, more fruits based diet. Proteins are very important and very good. But the meat, the guidelines recommend that meat should be part of our diet, not for 2 or 3 times a week, not more than that. Eggs are a very good source of protein, eggs. It's always fine to get some extra, protein, for example, those protein shakes and those sort of things. If you are not diabetic, obviously, if you are diabetic, then you have to watch your calories and you have to be more careful that because a lot of times when we are treating patients, we're giving them a lot of medications to prevent, for example, nausea, vomiting. We're giving them a lot of steroids that affects their glucose levels and that goes up all the time. So that's another problem. But if you are not, then you should really be taking a lot of good nutrition, balanced nutrition. Even though if you don't have a good appetite, it's important to make sure that you are eating. If you cannot eat, if you cannot eat a full meal, because you may not have an appetite for a full meal at a certain time, keep eating something every couple hours, few hours. So please make sure that you're maintaining your weight. You're not losing weight during treatments. And the studies have shown that, especially we see that in head and neck cancer patients because there are a lot going on in the head and neck area. And then everything else is going on, and then they are just keep losing weight, and then they cannot handle any treatments. So the patients who maintain their nutrition good, who can maintain their weight, who can maintain their good nutritional intake, they do overall better. Yes, please.
What about the effect, or should we be eating organic food, vegetables, or?
So, thank you, good question. So there are a couple of things which are important to understand. I think it's important to discuss here. One is that a lot of patients worry about carbohydrates or sugars, that it feeds the cancer. So there is no truth in that. Okay, everything we take eventually ends up being a glucose molecule. So our body needs energy and food. Similarly, cancer also. So there's a lot of information out there about that you sort of somehow deprive yourself of this and that would help to shrink the cancer.
Ketogenic diets,
yes.
They talk about ketogenic diet,
diet.
Cancer, that whole thing.
Yes, but there is not much scientific data to support that. I'm sorry, what was your?
As it relates to organic.
Organic, yes. So organic. So not really. And I think in general, as long as you are able to eat something fresh, not out of a can. So we know that the canned food is associated with some increased risk of different cancers. As long as, but I'm not, again, these are the minor things, by the way.
Okay.
Yeah, and but fresh food, if you're preparing something fresh, that's always good. Again, vegetable based, more fruits in diet. Grains are very good. Meat is fine also. I'm not saying about, but there has to be a, because sometimes some people just eat either. Some people are just only eat meat all the time, and there are some of us who don't at all, or who just vegetarian. And so I think both extremes are not right. There has to be something in the middle. The balanced diet is the right diet, and it doesn't have to be organic. No, yeah.
Thank you so much.
You're very welcome. Oh yeah, one of the last things, hydration is very important. So during treatments, especially hydration. So hydration is extremely important, and then it's good to have those, the liquids or the drinks which has a lot of electrolytes in it, like Gatorade and those type of things. So it's very important to keep yourself hydrated during treatments.
Pedialyte, they
Pedialyte
have
is
so much out in the grocery
Yeah.
stores now
Yes.
for hydration. It's
Yes.
crazy. Something's called IV. I'm like, what? So when I saw that, I was like, oh, okay. Yep. But yeah.
We don't have any questions from online, so that's.
Okay.
Thank you so much.
You're very welcome.
For
No,
really being here.
thank you very much.
Really
So much.
appreciate it very much. This has
It was-
been incredibly helpful. And it's also being recorded, so if anyone, still wants to see it, if wasn't able to make it tonight, we'll have it. It's a very great resource. Thank you.
You're very welcome. It was very nice meeting you all. Thank you.
Thank you.
Yeah.